Hi again. So in this last lecture of this class, we're going to be talking about the PT role in acute care. So during your first forum post, when I had you write about what you wanted to learn from this class, one of you said, I would like to learn more about the PT role in acute care. And I was like, duh, why did I not include that in the first class? But then I thought, well, this whole class is sort of backwards, so I'll just add it in the very last lecture. And now that you have a little bit of experience, maybe it will be a little bit more meaningful. So thank you to whoever wrote that in the class, because I totally hadn't even considered that somehow. So PT roles. So I'm going to talk about kind of what we do and what we don't do, or what we maybe shouldn't do is the right term. So of course, we're evaluating a patient's current movement ability. We are collaborating with others and working with that patient directly to optimize their movement ability. We do make discharge recommendations a lot, and you might hear sometimes PTs being referred to as glorified discharge planners in this setting. I like to think, we are the experts in this for a lot of reasons. So we're really good at evaluating a patient's movement ability and determining what the best place is for them to go, also taking into consideration their medical status and their rehab potential. So yes, we do a lot of discharge planning, but that certainly isn't all that we do. However, patients are about 3 times less likely to be readmitted if what we recommend is actually followed. So if we say a patient needs to go to subacute rehab, but they end up going home, they're 3 times more likely to be readmitted than if they had listened to our recommendation. So the other thing we do is address limitations in order to get patient to their next destination. So that's kind of where it's different from other settings. So yes, we want to optimize their function, but our scope is a little bit more narrow, I guess would be kind of the word. I don't know if that's the right word, but our primary focus is to get the patient to their next destination, whatever that might be. So we might, for that reason, be focusing on more big picture impairments than you might be in like an outpatient orthopedic type setting. And I put an asterisk here because the next destination is not always leaving the hospital. Sometimes people are in the hospital indefinitely because maybe they need to get a certain medical procedure. Maybe they need a transplant. So I've had several heart and lung transplant patients who, on the pre-op side of things, might have been in the hospital for a year because they needed to get a transplant before they could safely leave the hospital. And sometimes they weren't yet listed for a transplant. So Caitlin talked in Complex Med about how with the liver, kidney type transplant, the physicians are really just now starting to take our considerations into account with listing. With heart and lung, they have done that for years, and we are part of that team, and they take our recommendations very seriously. So if a patient is considered quote unquote frail, they will not be listed for a transplant until we fix that. So that might be what we're working on, is trying to get that patient to the point where they can be listed for a transplant, or, going somewhere else if they could be um, strong enough to potentially survive any kind of major surgery, not even necessarily just a transplant. So next destination doesn't always mean leaving the hospital. What we don't do, walk patients. So instead of walking patients, right, we're working on gait training, or we might be working on aerobic conditioning. Remember, that's a Therex code, not gait training. Might be working on dual task training, training a patient to appropriately use an assistive device, caregiver training. We're not patient walkers, right? We're also not patient movers. Some hospitals have lift teams for that, where if a patient needs to get up to a chair and it's a difficult transfer, the lift team is trained on getting that patient up to a chair. We also don't do repeated passive range of motion on people who have full range of motion. So instead, we're assessing tone, assessing for somebody's potential to develop contractures, looking for any splinting needs and getting splints for that patient if that's what's needed. We might be doing manual therapy. So we might be doing like some joint mobs or soft tissue work to improve their range of motion and or ease of movement, or doing caregiver training to perform range of motion so that the patient doesn't develop contractures. So just keep your skill in mind, and keep this in mind also, not only when you're doing what you're doing, but also when you're documenting it. It's easy to lose that skill when you're documenting why you were doing something. So I wanted to give this example kind of specific to acute care, of a patient's function and how it might change throughout the hospital stay. So let's say a patient came in with an ischemic CVA, and then they're starting to get better. So they were able to get TPA. They've been medically optimized. They're having PT and OT. So things are going great. And the y-axis is patient function. That's getting a lot better. But then as a result of that TPA, so a side effect that sometimes happens is that the patient then has a hemorrhagic CVA. So they call that a hemorrhagic transformation. So then they had that, and now their function is lower than it even was before they came into the hospital. So then everybody starts working with them again. Maybe they have to have neurosurgery to have some of that blood evacuated. They've got stellar neuro nursing care. They've got PT, OT. Now they also need speech. So they're getting better, but they're not as good as they were initially after that improvement. Then something else happens. Now they've got pneumonia, they have respiratory failure, maybe they had to be intubated, and now their function is lower than it's ever been. Then they get put on a ventilator that helps improve their pulmonary function. They're still receiving PT and OT, so they're starting to get better. But you can see, so what's discouraging about this, and this can be a big source of burnout in acute care, is that the patient came in at this level of function. I don't know how to change my pen color, so it's the same color as the screen. So they came in at the same level of function and they're leaving at the same level. So that can be really depressing, right? And it feels like all this work that you put in throughout their maybe month-long hospital stay didn't really do anything. So I think what's important to keep in mind is that if we weren't involved in this patient's care, this is where they would be, they wouldn't be at the same level that they're at now. So sometimes instead of improving, we are really maintaining or preventing further decline, and you might be thinking, well, insurance doesn't like those words. And that's true. Insurance doesn't like the word prevent or maintain. But in acute care, that's often what you're doing. And I think that you have to be able to document why that's the case. So, in spite of all these medical complexities that this patient has experienced and all these multiple setbacks, they're still at this level of function. Whereas if it wasn't for PT, they would be all the way down at this level of function. So again, I think documentation is important to show your skill and why you're needed. I wanted to put this in here. This is from an article that was written by the president of the Journal of Acute Care PT. So he's also a PT. So I'll give you a minute to read this. So pause it if you need more time, but basically he is saying that his father has paraplegia. He had polio, he had post-polio, and so at baseline, he's kind of wheelchair bound and does transfers. And then he had to be in the hospital for something completely unrelated. And because of that and his already low level of function, he ended up having to go to inpatient rehab, and then he had to have home care after that. So this president of JICPT is writing that multiple times throughout that whole course of healthcare, he heard multiple times that the patient didn't need PT because he couldn't walk. Because he couldn't walk at baseline before the onset of his recent medical problems. So this is being told to a PT from other PTs, from nursing staff, from physicians, from other healthcare providers, including ourselves. So I put this in here to kind of illustrate that sometimes we are our own worst enemy, especially in acute care. And I actually saw this happen just like last week. In home care, I was on this email chain about a patient, and they were saying this patient, the nurse was saying this patient needs PT now. And the response from his previous PT was, well, can he walk now? Because if not, then we don't need to see him. And that just, blows my mind. So you guys are really, you're probably not going to feel like you can speak up in those types of situations as new grads, but you know more than you think you do, and you should speak up, because I think that sometimes we're doing a lot of damage to our profession in situations like this. So some things to think about, like when you're determining whether a patient in the hospital needs skilled PT or not. So one is their baseline functional level. So you want to compare that to how they are now. And sometimes this is a little tricky. So you might have a patient who is quote unquote bedbound at baseline. Maybe they live at home with their family, but they use a Hoyer lift for transfers. So on the surface, that might be like, no, they don't need PT, but you have to consider what else is going on. Like maybe they fell out of bed and broke their femur, and now family needs training on how to safely care for that patient in the setting of a femur fracture. So just because somebody is dependent at baseline doesn't mean that they don't need PT. And certainly because somebody's not ambulatory at baseline doesn't mean they don't need PT. And I'm confident that you all know that and were as appalled by that story as I am. Potential for improvement. So you might have to see a patient a few times before you can really make a determination on this, but they should have some potential to improve with PT services, or potential to decline without PT. So this is kind of where working in the hospital setting becomes a bit more unique, because we know that many patients who are in the hospital have a potential to decline because they're not as mobile as they are at baseline. And you know all about those effects of bed rest that people will experience. So is it our job, again, to walk patients and get patients up to a chair? No. However, if it's a complicated patient, nursing might need some additional assessment and guidance on what's appropriate and safe to do with that patient. So you might have to evaluate a patient. Maybe you evaluate them and you only put them on your caseload for once a week to check in and make sure that things are going as expected. All things to take into consideration. What are the goals? Are there any new environmental barriers? So like, is the patient moving residents? Like maybe they come into the hospital with something, and this happens more often than you would think. For some reason, they're moving while they're in the hospital. Their family's moving all their stuff to another house. So you might have to see the patient to problem solve through that, especially now that they're in the hospital and maybe have some new deficits. They might need a new assistive device or a new plan of care. So often we will get consulted for this patient said that he had a cane a long time ago, and now it got stolen and we think he might need one. So you might need to go assess, does he actually need a cane? And then you might need to obtain that for him. And then often assistance needed for discharge planning. So this is where things get a little gray sometimes. Like you might get consulted on a patient who really doesn't have any mobility impairments, but maybe they have something medical going on where they maybe they need an IV antibiotic for 6 weeks and the doctor doesn't want them to go home for whatever reason, like maybe their home is dirty or they can't manage it or they're a drug user. So you might get called in to officially make this discharge recommendation. And this is where I think we get relied on too much when it comes to discharge planning. So you might need to educate the physician at that point of, well, it's not a functional reason why she needs to go somewhere. It's a medical reason. So that's really your responsibility to write that recommendation to the insurance company and not mine. And then need for PT input. So again, that could be similar. Sometimes you might just be like, sometimes I'll be walking down the hall and a nurse will be like, oh, hey, are you a PT? Can you come in here and just check this out and see if this person needs PT? So sometimes it might be, a lot of times it's things like the nurse is concerned that they are losing range of motion or that they have like an ankle contracture. So sometimes you just might quickly go in and assess that and say, yeah, get a PT order, or no, I think they're fine, just keep doing what you're doing. So often I'll hear complaints from PTs that, you know, physicians don't understand what we do, or, you know, nurses don't understand what we do. We're getting all these inappropriate referrals. And I think that, like, my personal opinion is that's our fault. You know, who better to educate other providers on what PT does than PTs? So just like if you were working in an outpatient orthopedic setting and you're probably going to be advertising your services, right, to doctors, I think that we need to do that in acute care. So we need to do regular education as far as what type of patient is appropriate to refer to us, what type of patient is not appropriate, what can we do for patients. We need to educate physicians who are our referral sources, as well as nurses, because nurses are the frontline providers who are the ones who are going to be most likely to recognize when there is a potential need. So educating them kind of our leads on what to look for and when to ask for a PT referral. I think that that's our role. I don't think that other providers should just be expected to know to know definitively what type of patient needs PT and what type of patient doesn't. So these are some additional excerpts from this same article from the beginning that I just wanted to, these kind of stuck out at me and I wanted to talk about a little bit. So he said, another concern I hear, this is again what I said, members of the healthcare team don't respect us. Have we contributed to that perception by promoting ourselves as the healthcare providers who treat patients with walking? So I think, yes, I think we have contributed to that perception. And again, this is our problem to solve. Or has this been an intentional strategy to reduce the workload on overburdened PTs and PTAs in departments that struggle with insufficient staffing? So I would say also yes here. And in class on Tuesday, we're going to be talking about a little bit about that. We're going to talk about how we kind of prioritize patients and how I think that this definitely plays into this, where I hear this from my colleagues all the time of, oh, they don't need PT. I think sometimes we go too far the other direction, where we have so many patients on our caseload, we can't see them all. So then we start to justify why we don't need to see certain patients. And I think it's a slippery slope that ultimately, instead of saying, I'm not seeing that patient because I have other higher priority patients today, we start saying, I'm not seeing that patient because they don't need PT, when that's probably not true. And he closed by saying the healthcare system will respond favorably to other providers who are willing to address the needs of patients with reduced functioning. And this is so true. And I've seen this intermittently throughout my career. At some point, when I first started, we had cardiac rehab working with patients in the hospital. So they were seeing a lot of our cardiac surgery type patients, and they were doing things that seemed to be pretty PT specific. You know, of course, cardiac rehab works with these patients in more of a subacute setting, but they were working with these CABGs, these heart transplants, these VADs post-op day one, where really an additional level of skill was required that I felt like we were uniquely positioned to provide. However, because our staffing was so bad, we kind of gave that up, and we eventually fought back and took it back. But I mean, we never should have given it up in the first place. Instead, I think the conversation went something like, well, we don't have time to see those patients all the time anyway, so it would be great if you guys could see them instead. And I think that that is just super important, that we maintain our role, and that we are intentional about saying, you know, we're not seeing this patient only because I don't have time and we don't have enough PTs, not because they don't need PT. So there's that article if anybody wants to read it. I found it interesting and discouraging all at the same time. So that's it for my PT role in acute care. Hope you guys learned something. Please let me know if you have any other questions about this or things you've seen, and realize that hospital cultures are very different across the board. And a lot of it will have to do with the types of PTs who you're working with, and kind of their motivations, their experiences, maybe their education level a bit. So keep that in mind. And the other thing I wanted to say, I guess, that I forgot is sometimes you are doing things that are not skilled PT because you're being a good team player. So you might not be billing for those things, but you know, sometimes maybe you poke your head in to go talk to a nurse, and you find them in the middle of like a difficult transfer with a patient who you don't know. So I would probably go in and help that nurse, you know, even though I don't know the patient. What can I do? Can I help you with this transfer? Do you need a gate belt? You know, just be a good team player. There are many times when I'm working with an ICU patient and the nurse ends up helping me with line management, you know, and is that their job? I would say probably not. I could have brought a rehab tech, but maybe I didn't have one. And they know that's not their job. I know that's not their job. We're just being good team players. So do your part. Sometimes that does mean wiping butts. I know everybody thinks acute care is wiping butts, but you know, if you take a patient into the bathroom and they go to the bathroom and they need help and you can do it by yourself, then just do it. You know, yes, we have our doctorates, but we're not above butt wiping. So I guess I'll close with that. What better way to close? But I hope that you guys can see how much I love acute care. I think it's a great place to work. And I hope that some of you will consider it, maybe more than said so at the beginning of this class. So see you soon. Bye.